Okay, so in this next video we're going to talk about the pathophysiology of how acute hemorrhagic diarrhea syndrome establishes itself in the patients that we see. So the actual mechanism of how it comes to be is that it's actually a really acute issue of dysbiosis, so where we have a dysregulation in the bacteria that we have in the gut. Normally there is an insult to the gut of some kind, so it could be a scavenging episode, it could be infectious, there could be something that happens to insult the guts, and we will then have a massive proliferation in these patients of Clostridium perfringens. And this bacteria is a normal commensal bacteria in its normal concentrations and populations, is normal in its normal finding within the lumen of the intestines. However, in acute hemorrhagic diarrhea syndrome, we have a mass proliferation of these bacteria, and in that they produce toxins and enzymes which break down the cells in the epithelium, and they will damage them and cause them to lyse, so where we have that water infiltration into the cells and they burst. So that's where we get a lot of diarrhea. We have a lot of water moving into the gut lumen because we've got all of those cytokines, proteins, things that are drawing water towards all of those molecules and solutes, and so that's where we have this diarrhea. Equally, when we've got that state of inflammation, so that's caused by us, the gut mucosa sort of reacting to this dysbiosis. We have that inflammation where the tight junctions between our cells become more leaky, so it might mean that the tight junctions are compromised and we have fluid sort of leaking into the gut lumen, creating the diarrhea. So often with these patients, when they present to us with acute hemorrhagic diarrhea syndrome, interestingly, they shouldn't be infectious in this time when they're being hospitalised for acute hemorrhagic diarrhea syndrome. Clostridium perfringens is not shed or as part of this process. It's really the toxins that cause the diarrhea, and that's a very local issue and not something that's easily transferable to different patients. It's a little bit like how we have patients with FIP, where they have that sudden mutation in vivo of the feline coronavirus. It's this very individualized disease process, so it might feel odd with these patients to not isolate them, but it's not always necessary. I suppose the only thing to consider is if we're not sure what disease process is we're dealing with, and we're thinking it could be acute hemorrhagic diarrhea syndrome, but we still have parvovirus as a differential, for example. If it's a presentation where it's more likely to be that, then it might be that it's more appropriate to barrier nurse these patients, but it's just a consideration that we don't always have to, because this isn't actually a disease process that is sort of easily transmissible. So the other thing I wanted to go into detail with is about anorexia. So we know that food is important, that's why I've got on this little world news. Food is great. Food is essential, and not just to the point where we need to build our sustenance throughout the whole body, but the actual gut cells themselves rely on nutrients coming through the lumen for their normal processes. So in the absence of nutrients coming through the gut lumen, we actually have atrophy of the lining of the intestines, and that impacts on lots of normal processes that would typically happen that sustain the immune system and try and prevent things like gut bacteria translocating, so moving through the wall of the intestine into the rest of the body. So we have suppression of crypt cell proliferation, so our crypt cells are a bed of stem cells within our guts, and so having suppression of those is really hard to then have a higher turnover of epithelium to try and support that mucosal barrier to try and prevent those what would normally be commensal bacteria translocating and coming through to places in the body where they shouldn't be. We have key amino acids that need to be present as part of a normal sort of gut mucosa, and we have reduced energy where we have no nutrients. We'll have reduced amino acid transportation, so it's just this can have a really big impact on our immune response, and it just means that the gut won't be responding normally to its normal processes, and it means that the longer that patient goes without nutrition and without food, the longer these cells go without what they need, and we start to see worsening and worsening clinical signs. That's where we might see that the sort of more local inflammation then turn to more systemic inflammation. We have that risk of sepsis, so with these patients with those compromised gut barriers, we can risk the bacteria moving through to parts of the body where it shouldn't, and there are parts of the body which the bacteria will thrive in, and that could cause a gut-derived sepsis. So it's really important in these patients that present with that, like that patient right at the beginning, that in my first video, where they have that really large profuse diarrhea and that patient looked collapsed and really compromised. If you're concerned about sepsis, when you do your triage, this is a time that you would definitely want to flag it to the vet and get that patient to be seen to immediately, because it's absolutely essential that that patient receives emergency treatment as soon as possible. So we are now going to talk about emergency treatment for these patients, which, as I said, is really vital and pivotal to making sure they survive that first time period where they present really peracutely. So with any emergency patient, we will triage that patient, and triage is a skill that is absolutely vital in that first presentation of any patient presenting to your clinic, and it can happen over the phone, in the waiting room, or it's an inpatient that's deteriorated. And triaging should happen exceptionally quickly, definitely within 30 seconds, mostly within 10 seconds. You are establishing if any of the key vital body systems are in jeopardy that could cause this patient to further deteriorate, potentially even die. It is really, really important skill to have. So in these patients, we look at cardiovascular stability, respiratory stability, and neurological stability. In any patient that's walking into your consult area, your waiting room, and they're interacting with the environment in a normal way, even if that's in a fearful or worried, or you can tell they're painful, if they're interacting with their environment in a normal way that you would expect, and they don't feel neurologically compromised and they're walking, I feel like these patients immediately pass neurological just within seconds of looking at them. I then will go on to look at respiratory before I touch the patient. So we're looking at respiratory effort. So do we have any sort of thoracic inlet movement? Can we see the ribs moving in a very shallow way, where we've got shallow breaths, or are we seeing a lot of effort where we've got abdominal effort being used to create those big chest excursions? And sometimes in patients with slim body conditions, you can really rapidly see the muscles of the thoracic cavity like contracting to try and get more air into the thoracic cavity. So you can tell that there's that effort going into their breathing. So any patient who is showing these signs, I would take them and want to get an SpO2 and say, I'm a bit concerned about the patient for this reason, and we're going to use a device in the prep area, or in my case in the ICU, just to get a bit more information about this patient. If a patient is panting, they can sometimes be tachypnic with their mouth open, and I think the way to differentiate that is sometimes how open their mouth is and how far out the tongue is coming, because if they're truly panting, they're usually expelling air and that heat, and they're using it as either an expression of their anxiety or pain or stress, or they're hot. Whereas tachypnea with their mouth open, the tongue tends to stay quite within the lower jaw, and you might have sort of some minor fluttering rostrally, but it doesn't really look as much of a pant. So I wouldn't say a patient who's panting is necessarily failing triage, but if they look like they're hypothermic, if they're an at-risk breed, for example, then that would be a cause for concern. We might want to get a temperature to try and rule out hypothermia. If it's a hot day, for example, or the owner doesn't have air conditioning in their car, which they might say at the triage. And lastly, cardiovascular. So this is where I will put my hands on the patient. So I typically, first off, will look at their mucous membrane colour, because that's a really, really quick way of seeing, is it a normal pink colour. If it's sort of pale or white, that is a sign that that patient needs to be seen very quickly. We want to ideally maybe stabilise this patient with some fluid boluses if required. They may need blood products, we would like to get a PCV. So I just want to get a head start on those problems. So if I'm seeing pale or white mucous membranes, that patient will need to be seen sort of immediately without waiting for the vet and waiting for a full consultation. I will also assess mucous membrane moisture. That's a case for sort of the dehydration, as we talked about, but it is important as part of a mucous membrane examination. And then we look at capillary refill time. So if we've got a patient that's got delayed capillary refill time, that's an indication of vasoconstriction, and so we've got evidence of compensation for our cardiovascular system working a little bit harder to try and maintain perfusion throughout the body. And if we've got vasodilation and we've got more like red mucous membranes, that's a sign that we've either got maybe a hypersensitivity reaction or that the patient is decompensating. So they've gone beyond compensating and they're decompensated, and that's where we're further down the track towards leading to death as part of this cardiovascular decompensation. So with these patients, it's really important to get them seen immediately. So mucous membranes can tell you a lot about the patient. If the patient's demeanour won't let you touch their mucous membranes, I think that probably tells you quite a lot about how well they are, because most of the time, if a patient is that decompensated, they don't really have the energy to stop you looking at their mucous membranes. But obviously use your professional judgment as to what's appropriate and what's not in terms of what the patient will let you examine. And then if they've sort of passed the mucous membrane examination, I will feel a peripheral pulse, and I will see if that peripheral pulse matches the femoral. Because if we've got dysrhythmias, it might be that we have mismatching pulses between heart, femoral pulse and peripheral. Peripheral pulses tell you a lot of information about perfusion in the wider body. If we're just using femoral, that talks about more central perfusion. What I really want to know is how much is our body compensating. If we've got vasoconstriction, I'll have poor or weak peripheral pulses, and if we've got hyperdynamic peripheral pulses, that's that sign of hypovolemia that we talked about, where we've got those large differences in pressure, and it's making the pulses feel very boundy. And the way I tend to differentiate it is if you have sort of strong pulses in a patient that you're not expecting strong pulses in, if they look really poorly, they look more collapsed, lethargic, they're poorly responsive, and their pulses are like bam, as soon as you touch the area, they're like right in your face, that might be more of a sign that it's a hyperdynamic pulse rather than like a strong normal pulse. But this is why it's good for us to examine all of our patients all the time as part of our pre-op examinations, our nursing consults, our inpatient assessments. It's important to get used to what a normal peripheral pulse feels like, so that when you see these patients, you can tell what the differences between normal and not normal is. And at the baseline, that is what our job is to say this is normal, this is not normal, and I need to seek my veterinary colleague to come and have a look at this patient. So if you do a successful triage and you've assessed all of those parameters, and any one of those bring that patient earlier to the clinical team for more in-depth physical examination, then you've done your job. If you leave the patient with the owner because you think they're safe to wait, obviously they might need veterinary care, but the whole point being that they are safe to wait. So triage should be very, very quick. It's not a physical examination, it's not auscultating all areas of the chest and getting like a full assessment of any heart murmurs or anything like that. It's literally, is this patient safe enough to wait?